Good afternoon, everyone. We're going to start the second session of aortic aneurysm. There is a slight change in the schedule. Dr. Amar Gad, he will give his juxtarenal aortic aneurysm repair, open versus gold standard at the end of the session instead of tomorrow. All right, let's go and start.
We'll start our first presentation is by Dr. Samer Koussayer. He's going to talk about hostile neck challenges.
Good afternoon. Good afternoon. Yeah, I think you're going to see out of slide be repeated from my morning lectures, so hopefully not be very boring. Sealing zone, again, we talk about it. We know that fixation is very important in the EVAR and could be life-saving. All of us, we like to get a good fixation. We have to stick to the IFU. It's diameter between 19 to 28, length at least 10-15, and angulation less than 60 with minimal thrombus and calcification. But real life is different. Many times we get this kind of neck. This is very nice paper done by Antonio. He did meta-analysis of 7 major studies in the EVAR, and he found that if you have a hostile neck, this will increase your type 1 endoleak about 4.5 and aneurysmatic mortality about 9 times. Another paper by Special, he looked at the influence of multiple hostile neck parameter, and he found that if you stuck to the IFU, your endoleak is less than 1% with mortality about 1%. But if you have 2 hostile neck parameters, this will increase to 6.7%, mortality 13%. And you have more than 2 hostile neck parameters, then your intraoperative endoleak will go to 16%, and the same for mortality. So what he concludes that if you have more than 1 hostile neck parameter, this substantially will increase your mortality, major adverse event, intraoperative endoleak, and adjuvant procedure. So IFU is important, but so does the neck quality. If you look at the first picture here, the first one, this patient, he's out of IFU because angulation more than 60, but we know this patient has a long neck. He will do very well with the EVAR. If you look the second one down, this patient is out of IFU, he's within IFU, but he has a reverse paper. So even he is within IFU, we're sure that this patient, because of the reverse taper neck, he will have an issue down in the road. So the binary IFU system may not be the best method to assess suitability of the EVAR. So if we have a short neck less than 10 millimeter, option as we said before, either we need to increase our sealing zone by going higher, by doing tuning of EVAR, or we need to shrink our repair. And again, not all short neck are the same. We have to differentiate between the neck length and the sealing zone. Neck length, by definition, is the length over which the neck diameter remains within 10% of renal diameter. And you can see in the green area here. The problem is that if you look at the last 2 slides here, both have a short neck, and we both call them short neck, but really they are completely different because of the difference in the sealing zone. Again, sealing zone, we mean that when you oversize 10% of your graft, the graft is still touching the aorta in this area. So this area where the graft is still touching the aorta, even we not oversize 10%, we call it a sealing zone. So this one, it helps us to divide the short neck is a 2 area. One with a short neck and long sealing zone, we call the hostile neck. The other one is short neck with a short sealing zone, we call inadequate neck. Why is that important? Because if you have an adequate neck with a short neck and short sealing zone, EVAR will work very well. If you have a hostile neck, then you need to shrink your repair by doing endo-anchor. If you have an inadequate neck, you have to go higher with a BVAR or FEVAR or even SHEVAR. So give you an example. Like if you look at this patient, the neck length is about 20 millimeter and sealing zone 25 millimeter. So he has a long sealing zone, long neck. So this one standard EVAR will work just fine. But if you take this patient, neck is 4 millimeters, it's very short. But look at the sealing, 10 millimeters. So we have a good sealing zone, even though short neck. So this one, EVAR will work, but you need to shrink our repair because you get a seal, but it's not strong. And this is the area where you need to use endo-anchors to help you stabilize your repair. And the endo-anchors, the way it works is to create stability of surgical anastomosis by providing a transmural fixation of endograft to the aortic wall, and it gives us, as we talked before, longitudinal and radial fixation. If we have inadequate neck, if we have 3 millimeter neck, and we have 5 millimeter sealing zone. So this one, we don't have short sealing zone, short neck, then endoanchor will not work. This one, we need to get a new neck which is 15 millimeter. And to get the new neck, then we have to do a SHIVAR, or we have to go do BVAR or BVAR. How we decide, of course, FIVAR is a more stabilized technology. It's a custom-made, it's a consolidated technology. The problem, it takes some time, it needs a lot of skills, whereas SHIVAR could be good for emergency and urgent cases, but the problem also, type 1 endo leak is an issue. But to get a good SHIVAR, as you mentioned before, you still need a neck, 2 millimeters, and the new neck should be at least 15 to 20 millimeter to get a good seal. And of course, you need to oversize at least 30%. So in summary, if you have an adequate neck, I think EVAR will work perfect. If you have a hostile neck, EVAR will work, but you need to add endo anchors. If you have an inadequate neck, it's better to do a SHIVAR or BVAR. So conclusion, hostile neck is among the most cause of re-intervention after EVAR. Inexperienced center AAA with hostile neck are manageable with conventional EVAR, but you need to use additional tool like chimney, endo anchor, BVAR, or FIVAR. And you have to understand the sealing zone concept, which play very important to pick a Bushlight tool for this patient. And finally, don't do any case if you have more unfavorable anatomy because it may get to trouble. And as I always said, if patient's young, open repair is always a good option. Thank you very much for your attention.
Thank you, Dr. Koussayer. So next we'll talk about laser fenestration with Dr. Pascal from France. Welcome.
Hello. So I have no disclosure. Thank you for the organizer to invite me, to invite us in this wonderful city that is Dubai. And I want you to present our experience on laser fenestration, experience that we shared with my dear colleague Hicham Kobeter, that is present today. So as you said, endovascular repair of complex aneurysms is mainly based on chimney graft or fenestrated and branched grafts technique. In that series, we have investigated the feasibility, safety, and effectiveness of performing laser fenestration of EVAR, also called LEVAR. So what are the indications? As you say, this is the hostile neck, but also the emergent situation. We have a lot of patients with post-EVAR type 1 underleak, as is it presented on that slide, but also a situation where we cannot delay more than 2 months. In France, at least, this is the time that it's used to have a FIVAR, and also the contraindication of FIVAR chimneys. It could be an occlusion of an iliac, for example. So in almost 5 years, we have treated 76 patients. It was 69 complex EVAR, I say juxta-renal or above the renal, and also thoraco-abdominal. And in most of them, 30, there was 30 type 1A post-EVAR underleak. There was also 7 complex TVAR. The medium diameter of aortic dilatation was 64. There were 201 target arteries, 17 celiac chunks, 62 SMA, 114 renal arteries, 1 left common artery, and 7 left subclavian artery. So what do we need? We need a Dacron, standard Dacron endoprosthesis. Most of the time it was endurance or valiant graft. To do the fenestration, we need the help of Aptus LE-FX, which is a steerable catheter, and of course the catheter of atherectomy turbo elite laser released by Philips, 0.9 millimeter. So first step, we do a CTA overlay fusion. CTA overlay fusion permits to locate the ostium of the renal artery ostia and the ostia of the target renal artery landmarks are represented, as we can see here, by a colored ring. You have above. The yellow one is the celiac trunk. The big blue one is the SMA. So the second step is the fenestration with the turbo elite laser catheter. So we bend the aptus, and then you have seen, maybe we can see that again if the video is closed. Okay, the perforation itself with the guide wire, and then we put the guide wire, 14 guide wire within. So once you have a good fusion as we have here, it's perfectly doable. So the third step is to put 7 French sheaths within the fenestration that has been enlarged, and as we normally do in fever, we put a covered stent. We expand a covered stent. It could be either an ICAST or Bentley stent, and that we flared as its proximal extremities at the end. So this is a case of 86-year-old man with a type A endoleak that was coming from another center, and this gentleman was scheduled for laser fenestration. We can see here that there is some difficulties with the left renal that is highly stenosed in front of a strut of the previous EVAR. So unfortunately, the anesthetist gives that man a cardiac stress test. And during the cardiac stress test, there was a rupture aneurysm. So we have to perform our operation in a hurry. And first we put resuscitation on the vascular balloon that permit us to set up general anesthesia and to operate the patient. Finally, we put an extension of with a Valiant cuff and perforated with 4 fenestration that are perfectly patent and with a good result on the aneurysm. And this chap has now 2 years follow-up without any event. So it is a case report. It's not EVAR, it's TVAR. It's a 55-year-old gentleman that came with a dissecting B dissection, type B, and we can see it's on the CT scan. That's at the beginning. It's a sort of a common dissection with anyway a big entry tear located at the isthmus of 17 millimeter and a diameter that is almost a little big with 42 millimeter at the isthmus. So the patient has a refractory pain, and we decide anyway to fix him. It was a little bit difficult because we are very close the supra-aortic trunk, as you can see here. So we decided to put 2 TVAR. We were in a semi-emergency. We put 2 TVAR. You can see here that we are very near the brachiocephalic trunk. There is a sort of emboli or bubble within the left common carotid. So the thing is that different from abdomen, that we have to do retrograde laser fenestration. So we have to come retrogradely, and the thing is that you have to be very perpendicular to the TVAR to accomplish the fenestration. And we don't really need fusion technique for that type of fenestration. So the problem is the angulation of the LCA with the arch, so we have to go very perfectly perpendicular. So we finally succeed, but we have to perform a bailout chimney of the brachiocephalic trunk because the TVAR has migrated a little bit further, but at the end, we have a quite good angio. We thought it was okay. The patient was asymptomatic, but we can say that we have, despite the aspiration of the thrombus, we have a ischemic left brain lesion that we can see here. And on the CT scan, there was a perfect result on the aortic arch, but as we are going to discover, It's a bit long, but I have no possibility to accelerate. Sorry. This is a good results on the aortic arch, but we can see further on because there is a collapse of the true lumen. But we can see this is on the left side, and in front of the SMA is collapse with the patient beginning to have a malperfusion syndrome. So we can see here, we can see the SMA is in the front. We can see here the SMA is practically collapsed. So at the end, we have to do a stabilized technique. It could be a little bit tricky, this sort of technique. But at the end, with a good CT scan showing a good expansion and the patient was perfectly well. We can see here from the inside the stents that are put in within the aortic arches. In this slide shows the good unbending of the stent. So what are the results? So on the abdominal part, the arterial ischemic time of the SMA was 31 minutes. This is the first artery that we decide to vascularize. Then come the renal arteries with 73 minutes. Celiac trunk is usually left at the end with 110 minutes. And for the supra-aortic trunk, it was 33 minutes, quite long for the subclavian, and 13 minutes for the left common. The procedure time is rather short, less than 3 hours, as well as the fluoroscopy time, 75 minutes. What is important also is the contrast. Because of the use of the fusion technique, the contrast is very low, 100 milliliter plus or minus 40, and with an irradiation that is quite acceptable. So the technical success was 96% with only 9 non-success, with 7 chimneys that were done on purpose, and we have to do 2 bailout chimneys on the celiac trunk that is sometimes particularly angulated. The mortality was during at 30 days was 7%, during follow-up 15%. There was no bowel ischemia, 1 patient was dialyzed, and 1 stroke. The mean hospital stay 7 days. There is a high reintervention rate, mainly for type 2 embolics, but some type 1. And total occlusion follow-up is, during follow-up, is 90%. We have published last year in a publication, 12-month survival was 91%, 12-month patency target 95%. Why to do a chimney? Sometimes
we have the conclusion, please. Yeah.
We have some arteries that are. This is, in conclusion, it will be the advantage of liver. I'm sorry to be a bit long. It's feasible in emergent and bailout cases, and there is, to our mind, less restriction compared to fever. We use the Sander prosthesis. We think that it's a bit faster and simpler than fever. The cost is it's half of fever. However, we do have some limits. This is the durability. Thank you for your attention.
Our next speaker is again Dr. Jamal Huballa, the chairman of surgery at the American University of Beirut. He was not able to be with us, and we'll have a recorded talk for him. He'll be talking about technical considerations in open aortic aneurysm replacement. That's not it. That's the wrong talk. Okay, I'm sorry.
So we can move to, so we'll go with Dr. Sam Yunus, who's going to talk about branched endovascular graft treatment for thoracoabdominal aneurysm.
Hello again, everyone. So I decided to share a case with you, move from the totally invasive to the minimally invasive case. Dr. talking about we treated a thoracoabdominal aneurysm using branched endovascular graft. I have nothing to disclose. So we have a gentleman, 50 years old, who presented to us with, presented to another hospital with a severe abdominal pain radiating to the chest. He was worked up, and part of the workup was CT angiogram that showed extent 3 thoracoabdominal aortic aneurysm. This is a CT scan. There is mild dilatation of the descending aorta just at the takeoff of the subclavian artery. However, it normalizes in the descending aorta and becomes severely aneurysmal at the celiac, SMA, and renal arteries, as well as the infrarenal aorta extending into the left iliac artery. These representative measurements of the aneurysm. Given the extent of the aneurysm, in this case we elected to perform endovascular repair. And for this case we chose the branched graft. For the branch graft, as you saw, many options today, the fenestrated, laser fenestration. This is another option for the thoracoabdominal aneurysm. You have to go through extensive sizing and planning, and accordingly you choose the stents. You have to keep in mind the sizes of the aorta, landing zones, certain diameters in certain parts of the aorta, as well as the visceral vessels, diameter, and takeoff. Just a little bit about the device. In this case, we use the internally branched EVAR provided by Atrivion, which previously Jotic, I believe. It has the stent is the stents over the graft. They have two types of stents: flexible stents proximally and distally, and much stronger stents in the middle. Proximal sealing zone between 38 and 33. You see on the next picture the branches of the graft that are actually pre-cannulated through catheters. Those catheter outer diameter 035, however, you have to cannulate them with 018 wire for the inner diameter. And it has 4 branches, which comes in an oval shape that provides you with a lot of room for different angulation of visceral vessels. So we didn't have adequate landing zone, proximally or distally. For that reason, we decided to start with first a TVAR. So in a standard fashion, we perform TVAR, and you see, oops, sorry. I can go back. I think I can't. Okay, we performed in standard fashion the TVAR to provide proximal sealing zone. And at the same time, we were talking, since this is a symptomatic aneurysm, which I would like to hear your thoughts later on, can we do it in a staged fashion or not, given the extensive coverage. After the deployment of the main body, which, sorry, we missed in the previous slide, through the catheters, we introduced 018 wires that snared through the left subclavian cut down and exchange into catheter that advance into the branch that needs to be stented. Over that, we had a 12 French sheath in the subclavian artery. 7 French sheath is introduced over a stiffer wire, and then the stent is introduced. I don't think the slides are moving forward. So we started with the SMA vessel. We confirmed the selection, introduced the sheath, and place the stent. Then we moved to the right renal artery. Again, we selected the branch and stented it. As for the left renal artery, so we had a challenge that the renal artery bifurcated immediately after the orifice, not leaving enough landing zone to save both the branches. So based on the CT angiogram, we decided to proceed with the upper renal artery, which provides about 70% blood flow to the kidney. And you will see this obvious after the stenting. That's not all the kidney perfused. Next one was the celiac artery. After selecting the splenic artery and confirmation over Rosen wire, balloon expanding stent was placed. And this is the completion angiogram of the visceral segment. Then at the bottom, you can see that there is a endoleak because there was no landing zone distally, and the patient had 6 centimeter infrarenal abdominal aneurysm. Therefore, we decided to proceed with the EVAR, which was already pre-planned. And in a standard fashion, we performed the EVAR, and this is the completion angiogram that showed the complete exclusion of the aneurysm. And this is the EVAR. This is the follow-up CT scan that shows a complete exclusion of the aneurysm with patent branches. Now, I brought this case just to show that actually this is a valid technology and another tool that we have in our kit, but there's a lot of things to learn while we're doing it. So in planning, if you notice, we left a segment of the descending aorta that was relatively healthy in size to provide spinal perfusion. All visceral vessels are patent, and then he has bilateral hypogastric artery patent and not covered. Also, we use all the protective mechanisms, including spinal cord drain. Despite that fact, the patient developed bilateral lower extremity weakness after surgery that we aggressively treated, and we were sent to rehab, and he made a lot of progress from that standpoint. Of course, you know, this technology is there, but as a new technology, it needs the right team and the right setup. And we're lucky that I have great partners that made this case look very easy. The whole case time was 3.5 hours. Thank you for your attention.
So teamwork is the best thing in vascular surgery. Are we going with Dr. Jamal online, or we will continue? Okay. So,
the next speaker is Dr. Carlos Bichara, Professor of Vascular Surgery in Loyola University and the Director of the Aortic Center, joining us from Chicago, USA. And he will be talking about covered endovascular reconstruction of the aortic bifurcation, CRAB.
Thank you, Hussam. And thanks to the organization committee too. It's been really a fantastic meeting. I'm learning a lot. So these are my disclosures. First I would like to start, you know, I think I love the aortobifemoral bypass. I think it's a great operation. We all know it's a very durable operation. But, you know, even in contemporary data, there's still, you know, up to 2% mortality and 5 to 10% morbidity early and late. And no, not every patient is a candidate for an aortobifemoral bypass, you know, considering some have cardiopulmonary disease, hostile abdomen. And to be honest, I mean, as much as I love this operation, I am an endo enthusiast for ABF. I think the way I see it is I can always do an ABF. It's different than converting above the knee bypass to below the knee bypass. And however, a lot of times I argue with my partners saying, well, this patient is a young patient, and then I always refer them to this paper by Dr. Balkin from Brigham, where they actually looked at their data, and actually the young patient had also worse outcome compared to the older patient, and they basically blamed it on increased disease virulence and maybe small size of the aortic and progression of infraangular disease. So one thing I always do, in especially usually it's female patients and they have small common femoral arteries, I patch the femoral artery and then I plug the bypass on the patch to kind of help with the compliance. And it seems like I've had some good results with it. But this is what we would like to see after these operations. And believe it or not, even this data that we were part of that randomized trial, also had a 30% wound complication rate every time you open a groin. So it's not a benign procedure. Meanwhile, there's some really good data and very encouraging data for endovascular treatment of task C and D, and even our recommendations, and the task recommendations also, you know, suggest in certain patients it can be used. So, I mean, the bottom line, we want to try to establish inline flow to the leg. That's the number one problem that we want to do. I personally, I'm not a big fan of external anatomic bypass. The only time I do it is in case of infections. But also endovascular technical failure for iliofemoral occlusions has up to 20 to 30%. So it's not, you know, it's not a low number. That's a pretty high number. But I'm going to show you some technical tips that I developed over the years that helped me improve the technical success as well as the patency of these cases. So So this is actually was one of my first cases when I started doing these. As you can see, when I tried to go retrograde, I re-entered above the IMA even. So, and then I wasn't keen on doing kissing stents at high, so actually I aborted that procedure and then came from the arm to basically recanalize them antegrade, and that's my approach for almost all of them. For some reason, antegrade approach, once you engage, for some reason you re-enter into the external without any re-entry device. I think the opposite is not true. Going retrograde, a lot of times hitting that bifurcation, for those of us who've been there with open surgery, you know how tough it is. So, but the problem coming from the arm is the wire and catheter can always go into the open side, the path of least resistance. And this is a technique that we developed and published a while back, 2012, where we actually use a balloon from the patent side to support the sheath as well as block the path of least resistance to recanalize them and stent them. But honestly, now with steerable sheath, I rarely do that. I think steerable sheath provides a good angulation and support to do that even in flush occlusions. So, so I'm going to go over some techniques that I think will be helpful to increase your technical success. I remember the very first case, I did this beautiful iliac endarterectomy all the way up to the external, to the profunda, and we couldn't cross with a wire. And if you do fem-fem, you just take it to the profunda, and you don't have to waste all that time to do the endarterectomy. So you could save at least an hour or two. So I went back, and then we developed this technique, which we call it the wire first technique. This is a patient that aorta uni and tissue loss, so we're able to pass a wire. And then this came to mind. I was like, well, even if I'm subintimal in the groin, why don't I just take out the wire, retrieve it, and then basically endarterectomize it and pass a patch or a bypass or something. We went through different iterations of this technique initially, and then stent it, because this way I know once the wire is through, I know I'm going to stent, and then I can waste the time to do endarterectomy and profundoplasty instead of doing an external atomic bypass, and then eventually stuck the patch, did antegrade approach, and the patient had amputation by podiatry. So, like I said, we call it the wire first technique, so I'm going to quickly take you through these steps. So basically, this is the picture. We pass wires. Once we know we pass the wires on both sides, then we know we can proceed with the full total our hybrid procedure, total endovascular procedure. But I think the key here, as I'm showing in this picture, is that I actually grab the plaque and I do eversion. I release, first I mobilize external iliac artery underneath inguinal ligament, and I really do eversion and endarterectomy. And what I'm trying to show you here is that actually I'm clean above the circumflex and inferior epigastric. So I don't like to stent under the inguinal ligament. I like to keep my stent away from it, so avoid any compression. I think that's one important technical point. And then I always leave my through and through wire for support, especially in these total occlusions. And then I always put an 8-French sheet because I can put stent through it. I can take pictures through this technique. And then also I do also eversion and endarterectomy into the SFA. So or sometimes I even do patch into the SFA and the profunda. And one of my partners, this was when I was in Houston, he always criticized me, saying, this is a cul-de-sac and that's going to create thrombosis. And then honestly, I haven't seen that happen yet. But the reason I like to do that is for future intervention. Now I have a stump in the SMA, I can engage it with the sheath, I can stent away from the profunda and avoid spillover disease from the SFA stent. So, so I think this is another technical point. So again, like I said, I try to do retrograde recanalization, but I usually don't waste time. If I'm not able, I go integrate. I don't do brachial approach anymore with the technique that we developed and we published our data on. But a lot of times you might be subintimal, which is okay. And then again, this is a case that I did 16 months later. It was still open. The patch is wide open, and the stump in SFA is open. And then I'm also pretty aggressive in exposing the profunda. I go on to second, third order profunda to really have a nice patch of it. And then this is a patient that we brought back, and eventually we were able to recanalize and stent 16 months later. A lot of times people ask me, what would you do with the internal iliac if it's open? Well, if you leave an unstented segment, it's going to shut down. You can't just rely on balloon angioplasty when you stent above and below it. So I usually, if it's a robust internal iliac, I put a short bare metal stent to preserve flow through the internal iliac. But again, a lot of times my profunda is wide open. As like I said, I go to second, third order. A lot of times there's enough flow coming retrograde from the cruciate pathway. I usually size 1 to 1, and like I said, most times I use cover stent except for the hypo. And then, so the dark arrow is showing where the femoral head is, and the red arrow is actually shows where the patch starts. So I think that's really important. Well, first, I preserve the circumflex and the inferior epigastric, and I keep my stent away from the inguinal ligament. Just a kind of a hybrid of cases. This is actually a patient that occluded ax bifam that were able to recanalize. So, I didn't really talk about syrup, but basically the syrup is you put an aortic stent and you come back with two iliac stents and cover it. But Aisha highlighted a little bit in this case real quick. I know time is up. But I was called to a TAVR room, emergently a patient, blood pressure went to 50, 60 systolic. We didn't have AFX on the shelf, but as you can see, I wasn't sure where the patient was bleeding. Was the patient bleeding from the iliac? Was it bleeding from the bifurcation? So while the cardiologist and the cardiac surgeon had the balloon up, I quickly sized the case, and then luckily I was able to put a gold limb above the bifurcation, and came back in with two VBX stents, and they basically did the syrup technique to treat this patient, as I wasn't sure really where she bleeding from, and then it was a very successful technique. But basically that's what syrup is. So cover stent in the aorta, and I'm coming in with like iliac limbs or cover stent. Thank you.
Dr. Carlos. Our next speaker is Dr. Khubayb Mapara from Cleveland Clinic, Abu Dhabi. He's going to talk about endovascular treatment of acute aortic occlusion.
Thank you, Sam. Just share the slides if I can there. Can you go back, please? So, good afternoon, everyone. Assalamu alaikum. It's an honor to be here. It's an excellent program, and I want to thank the organizing committee to give me a talk to present. I feel honored. So the task given to me was to talk about acute aortic occlusion and its endovascular management. Following Dr. Bichara's talk about chronic occlusions, I also want to say that I love open surgery, but there are times when endovascular management may be more suitable. I have no disclosures. We all know acute aortic occlusion is a rare but devastating event. Despite all the surgical advances and post-op care, ICU care, the 30-day mortality in most of the series still remain around 30%. In some series, some of the older series, the mortality is as high as 75%. So this is one of the most lethal pathologies that we deal with. The etiology is pretty much similar to most cases with like acute limb ischemia, either thrombotic, inside the thrombosis of a disease in atherosclerotic aorta, or embolic, mainly cardioembolism. And the etiology is shifting, as we all know. In the last couple of decades, it's more thrombotic disease, and the patients present less dramatically because of the presence of collaterals. There are some other rare causes of acute aortic occlusion, but for this purpose, for the purpose of this talk, is mainly the first two I'm going to talk about. So location-wise, 75% of the patients, it's infrarenal aorta. Juxtarenal occlusion usually happens in patients with chronic disease, and suprarenal aorta is even rare. It's important and obviously needless to say that the more proximal the involvement is, the more dramatic and severe the symptoms would be because of spinal cord ischemia, visceral ischemia, renal ischemia, and so forth. So clinical presentation, as we all know, is quite dramatic. Acute onset of lower extremity pain, weakness, paresthesias. Femoral pulses are not palpable bilaterally, but as we all know, the pulse exam can be very variable depending on who's examining the patients. So despite this dramatic presentation, there are times when this diagnosis is often delayed. We have all seen those patients. Usually, they're mistaken for stroke or spinal cord lesions, and diagnosis can be delayed, which can be devastating. Expeditious revascularization after prompt diagnosis is critical for a good outcome. Traditionally, axillary femoral bypass or extra anatomical bypass has been the go-to operation for these thrombotic occlusions, and thromboembolectomy is reserved for patients with settled embolus. Direct aortic reconstruction is quite rare, and is usually associated with a bad outcome because of many reasons. So why even endovascular methods? Why are we talking about this when the extra-anatomic bypass is expeditious, it's quick, most people are aware and very familiar with these operations? Well, despite all the advances, the mortality curve of this pathology has remained unchanged. And a lot of these patients have coexistent or uncorrected cardiac comorbidities. Some of them present with acute coronary event while they have acute aortic occlusion at the same time. So a minimally invasive approach, minimal anesthesia, can be advantageous. In addition, groin complications can be Achilles heel in these emergent situations. Most of the patients we deal with are obese, diabetic. Some of them have, in these situations, end-stage malignancies, and these are malnourished patients. Groin complications can really limit their progression. This is one of the patients we took care of a year ago with acute aortic occlusion, delayed presentation, obese, diabetic, who did very well. We were all happy. 4 weeks later came in with wound issues. We were able to get her through this, salvage it with eventually a rectus femoris flap, but required a prolonged hospital stay and multiple trips to the OR. So there are diverse endovascular options available. Over-the-wire Fogarty thrombectomy is probably the most old-school way of doing it. You do require bilateral groin cut-downs. In my book, or in my opinion, catheter-directed thrombolysis or pharmacomechanical thrombectomy in acute aortic occlusion has a very limited role. You don't have time to mess around with catheters and do thrombolysis, and these people usually present with profound ischemia. However, it has been described. Percutaneous vacuum-assisted aspiration thrombectomy is relatively new, and I don't think it has been described in aortic occlusions. Obviously, once you have cleared the thrombus, and if there's residual thrombus left or there's a plaque that you unmask, stenting and angioplasty is a very viable option in that situation. So I want to share a couple of cases we recently took care of in our hospital, all treated endovascularly through vacuum-assisted thrombectomy. 56-year-old, typical symptoms of acute aortic occlusion. However, at the outside facility where he initially presented, neurological causes were entertained. He actually had an MRI of the spine initially. And then when he developed mottling, that's when it was noted that maybe this is a vascular catastrophe. So he was transferred, and just before transferring, he had chest pain, hypotension. He eventually came here. This was his exam in the OR, mottling all the way up to the groin. He was insensate, he was paralyzed. He also had clear evidence of STEMI. His troponins were high, his bedside echo was with very compromised EF. Clearly this was a settled embolus. We took him to the hybrid room. Cardiology first actually did through the arm, they did a cath, and they found multi-vessel coronary, diffuse coronary artery disease. He was already on heparin. He was already loaded with antiplatelet agents. They did not want to do anything at that point. We proceeded with bilateral. This is a CT scan, infrarenal aortic occlusion, percutaneous access under ultrasound guidance, local anesthesia. This is the clot burden that you see through a retrograde aortogram or angiogram, and we used penumbra 12 French bilaterally, got a bunch of clots out. At the end, both renals were patent. There was no evidence of embolization. You can see the IMA patent as well. And there is this burden at the aortic bifurcation, probably residual thrombus, which we weren't able to clear. And did bilateral kissing, angioplasty, and stent with balloon expandable, essentially VBX stents. And we had an excellent result. You can see his internals are also patent. So this is the first time, I think, it has not been described in the literature as far as I know for using CAT12 for aortic occlusion. Another patient, again, recently, 57-year-old, more chronic patient. She was admitted with GI bleed. She has a history of liver cirrhosis, but it was compensated. Some hypercoagulable state on Coumadin, which was on hold because of GI bleed. She came in, and then she was then had left greater than right lower extremity weakness, absent femoral pulses, acute ischemia. Took her to the hybrid room, bilateral groin cut down. This was a CT scan. Juxtarenal aortic occlusion, as you can see, patent superior mesenteric artery, bilateral renal arteries are patent. We were able to pass a wire easily, well, actually not easily, with some challenge. And then, after thrombectomy, I took a picture and I was like, okay, well, here we go. The left renal and SMA, it was embolism there. You don't see that here. So I got into the left renal, got into the SMA, and then used a CAT8 and performed aspiration thrombectomy of the left renal artery and the SMA. And on the completion aortogram, you can see that the left and right renals are patent SMA fills. So you're able to take care of the intraoperative complication through the same modality we did the case. So again, I don't want you guys to walk out of this talk thinking that I'm proposing that endovascular is the tool that you should use for acute aortic occlusion. Vascular surgeons are in a unique position that we have a lot of tools in our toolbox. And our goal in acute aortic occlusion is to expeditiously and efficiently clear the thrombus, restore the flow, whatever means you use. And there are some potential advantages of using this kind of a technique. This is a rare disease. It's a lethal disease. There's no prospective study that I'm aware of that guides that this is the treatment. My approach in these patients is I take them to the hybrid room, do bilateral groin cut downs, I pass a wire, and if I'm able to pass a wire, then I proceed endovascularly and I take care of them in that fashion. If I'm unable to pass a wire after 5 to 10 minutes, I immediately convert to an XV bifemoral bypass. Thank you very much.
Okay. So we'll go back to Dr. Jamal Huballa's talk. Have it loaded yet?
Good afternoon. Thank you, Mr. Chairman. Aortic graft infection is a dreaded complication of aortic surgery occurring anywhere from 0 to 5%. It can occur early or late. The organisms involved include gram-positive bacteria in about 60%, gram-negative bacteria in 30%, and anaerobes in 8 to 10%. The clinical manifestation can be confined to the abdomen with unexplained sepsis or some form of GI bleeding, and it can extend to the femoral area presenting with groin infection, inflammatory mass, draining sinus, or anastomotic pseudoaneurysm. Some of the key diagnostic issues are, is the graft infected, is the body of the graft involved, and is the anastomosis involved? Sometimes the diagnosis is obvious when you have an exposed graft, but many times the diagnosis is undetermined, and we have a lot of diagnostic modalities to help us in determining the process. CT scan plays a significant role in telling us what's going on, especially in the presence of fluid around the graft or gas around the graft. When coupled with angiography, it can help identify infection-associated complications such as an anastomotic pseudoaneurysm or anastomotic bleed, and it can help in the plan of revascularization. The new kid on the block is PET scanning, which is promising to be a highly sensitive and specific test and a valuable adjunct in the diagnosis of aortic graft infection. Now, surgical exploration, however, remains the most reliable method for determining the extent of the graft infection. Once a graft infection is made, the diagnosis made, the therapeutic considerations are numerous. The conservative management with no graft removal is based on anecdotal reports. It's used only in very high-risk individuals, especially if the indolent infection, and it has the risk of persistent sepsis, anastomotic disruption, and rupture, and is associated with very high mortality. Now, the graft removal is the gold standard, whether partial or complete. Partial is done for infection limited to the femoral area, where you can access the uninfected graft through a retroperitoneal or transabdominal approach, and then separate it, and then go over to the groin and remove it. Revascularization to follow is through an obturator bypass, fem-fem bypass, or an axillofemoral bypass. This is an example of an obturator bypass. If the whole graft is removed, then one possibility rarely happening is a no revascularization, which is when the bypass is an aortofem done in the empty side for an occlusive disease. In all the other situations, usually revascularization will be necessary. Revascularization can be through a traditional axillobifemoral bypass when the infection is limited to the abdomen and the groins are clean and non-infected. However, when the groins are infected, then you have to do an axillobifemoral through atypical routing or do bilateral axillofemoral bypasses. And these bypasses can be either done immediately after graft removal, or they can be staged, done a few days before the graft or immediately before the graft removal. The advantages of the staged revascularization is that it decreases the operative stress and eliminates the ischemia during graft excision, However, it requires typically 2 trips to the operating room with the risk of infection or thrombosis. Now, we've had a strong experience with infected aortic grafts at the University of Iowa, and our approach typically was complete graft excision, extra anatomic revascularization, and done prior to the graft excision. Typically, we approach the vessel, especially if the groin is involved, through a lateral approach, lateral to the sartorius muscle as shown here. This is where the previous incisions were. And you get proximal control. Occasionally, you have to go suprarenal and rarely celiac to dismantle the graft. And most importantly, we breed the stump and close it in 2 layers. And after that, you have omental flap coverage. The literature, however, did not show excellent results with axillo with this type of reconstruction, showed low patency rates, high amputation rates, risk of stump rupture up to 27%, and reinfection in the range of up to 27% with a high late mortality. As a result, people were looking at other options, such as the anatomic revascularization. And the options here include different type of conduit. The rifampin bonded grafts works well for the less virulent and low-grade infections, Staph aureus and Staph epi. However, they are less effective in infection scores by MRSA and gram-negative strains. Silver-coated grafts seems to have wider antimicrobial activity with a low reinfection rate and low amputation rate, and seems to be promising. If you want to avoid an autologous graft, then if you want to avoid a prosthetic graft, then your autologous options include the vein reconstruction with the neo-aortoiliac system, the NACE procedure, advocated by Claggett and his group. It has the lowest infection rate using the femoral vein as a conduit, has the lowest infection rate, lowest graft thrombosis rate, but it has this advantage is the harvesting difficulties in the emergency setting, a longer operating time that may not be tolerated by the elderly, along with issues with venous morbidity, DVT in up to 22%, and chronic venous insufficiency in up to 15%. Also, despite being autogenous, they can still get infected with poor outcomes in some gram-negative microorganisms, MRSA, especially in the presence of concomitant sepsis or an aortoenteric fistula. Another option is the cryopreserved allograft for aortic infection. It seems to be a promising technique, but has limited availability, and it is plagued by the graft-related complications down the line, including aneurysmal dilatation and graft rupture. Now, the newer technique is the xenopericardial graft, bovine pericardial graft, where the experience is still limited, but seems to be a promising technique with comparable mortality and morbidity and good data on the follow-up. If you try to compare all these treatment modalities, it's very hard to make sense out of comparing them together. But one meta-analysis that was performed showing comparing the in situ revascularization over the extra-anatomic for mortality, graft occlusion, amputation, and reinfection showed that the in situ reconstruction fared better over the extra-anatomic in all events. Now, as a result, they recommended in situ reconstruction as first-line treatment, providing the polyester silver grafts for the older patients and vein for the younger patients. Now, however, if you have an aortoenteric fistula, there are some systematic reviews showing that an axillobifemoral bypass and graft removal in a staged procedure, extra-anatomic, is a better therapeutic option with lower mortality than the non-stage or the in situ reconstruction. Now, the guidelines of the European Society for Vascular Surgery, which were based on that meta-analysis I presented earlier, are that for patients with an abdominal aortic infection, in situ reconstruction with autologous vein should be considered the preferred method, while the other vascular grafts, while the other cryopreserved allograft and silver-coated should be as alternative solution. And for patients with large abscesses or multi-resistant infection, the recommendation is for an extra-anatomic reconstruction should be considered. In an emergency setting, you may consider an EVAR to temporize the patient as a temporary measure. Now, after these guidelines came out, there's a big study that came out, a national multi-center trial, showing comparing the in situ to the extra-anatomic, showed no difference between them and no survival difference comparing the vein to other strategies, which is confusing the issue a little bit. In conclusion, infected aortic graft remains the most challenging condition. The management should be individualized based on the infection and the center's experience, in situ reconstruction using is an attractive option for low virulent organisms and for virulent infections, and aortoenteric fistula and X-ray anatomic reconstruction is a preferable option. Thank you very much for your attention.
Again, would like to thank Dr. Huballa, despite his other commitments, was continued his support and provided his talks. We have an additional talk by Professor Amar Gad from University of Cairo, who will be talking about juxtarenal triple